am Dr. Rashmi Aggarwal from KEM Hospital, a third year DNB resident. So we have a patient called Bhumi Dubey, a 10-year-old female student, a resident of Pune. And she has came to us with the chief complaints of right-sided nasal discharge since 3 months and right-sided nasal obstruction since 3 months. The history has been given by the informant as well as the patient. History of presenting illness. The patient was apparently asymptomatic 3 months back. Then she developed nasal discharge from the right side of nose, which was mucoid, non-blood stain. It was non-foul smelling. It had no diurnal variation. It was aggravated by episodes of common cold and seasonal change, and it was relieved by medications. Patient also complained of nasal obstruction since 3 months, which was on the right side. It was insidious in onset. It was progressive, and currently patient has complete nasal obstruction. It is more on expiration. There is no diurnal variation, and it is aggravated by episodes of common cold. There are no relieving factors. Patient also complains of mouth breathing and a change of voice since last 3 months. There is no history of sneezing. There is no history of snoring. There is no history of facial pain or headache. There is no bleeding from the nose. There is no history of fever. There is no history of trauma. There is no history of smell disturbances. There is no history of watering of eyes. There is no history of visual disturbances. And there is no history of ear pain, ear fullness, or decreased hearing. Past history, patient is not a known case of asthma. She doesn't give any history of recurrent chest infections. And there is no history of any drug allergies. Treatment history, there is no significant past surgical or medical history. Family history, there is no history of similar complaints in the past, and the personal history of the patient is normal. General examination was normal. The child was conscious.
Dr. Rashmi, hold on.
Yes, sir.
So, basically you are presenting a case of 10-year-old child with unilateral obstruction and unilateral nasal discharge. Can we come to the first slide?
Sure, sir. Here.
First, before this. Yes. So you are presenting a case of nose. So does age has any bearing? Basically,
yes, sir, it does.
Case presentation is just like solving a case in which you get some clues from the patient and simultaneously you ask some question to clarify your doubts and thoughts. Okay. And after this exercise, you come to a conclusion, either a single conclusion or a differential conclusions. Okay.
Yes,
so when you discuss about age in a case of nose, so what does it has meaning for okay, what is the bearing of age in
so
a
sir,
nasal case?
if we discuss, so if we think of somewhere near the elderly people, we would go for think of more of a malignancy. If we are somewhere around 40-50 years, we can think of an inverted papilloma. If we are into kids, we would think more of a impacted foreign body or a anthracoinal polyp. If the obstruction is bilateral and the older age group, then we would think of ethmoidal polyps.
Okay. What about neonate?
Sir, neonate with nasal obstruction, we can think of choanal atresia.
Right. So bilateral choanal atresia is basically detected right at the birth, but may I ask why?
Unilateral.
Why bilateral
Because
choanal atresia?
The child is because the child is not able to breathe through the nose, sir, and there is
they are obligate nasal breather. So if they cannot breathe through nose, so they cannot breathe through mouth, and they go into dyspnea and cyanosis and all those things. So, but at times unilateral choanal atresia we missed out.
Yes, sir.
Have you seen any case of unilateral choanal atresia coming in
Yes, sir.
adult
Yes,
age?
sir. I have seen.
Okay. So
I
uh,
have not seen any coming in adult age, sir, but I've seen a neonate.
okay. Then comes your gender. Does gender have any bearing on nasal pathologies?
Yes, sir. Like atrophic rhinitis, it is more common in females.
Okay.
Then JNA, it is more common in males.
More common in males or exclusively in males?
It's exclusively seen in males.
It's a testosterone dependent tumor. So basically it's seen in males only.
Yes.
And
Yes.
inverted papilloma?
Inverted papilloma, sir, is also more commonly seen in males. I'm not sure if it is exclusively seen in males, but
No,
it
no,
is
no.
more
It's
commonly
not
seen in males.
explosive tumor of male gender, but it's more commonly seen in males. Okay. Then
Yes.
the occupation. Does it has any bearing in nasal pathologies?
People like farmers who are exposed to pollens or people who are more exposed to dust, they kind of have more allergic conditions
Allergic.
than
Okay.
others.
And uh, any risk factor for malignancies like furniture worker?
Wood dust,
Up.
wood dust, yes, sir,
Yes.
wood
Yes.
dust,
Paint fumes
dust,
and heavy metals exposure. Basically, these are seen in
yes,
manufacturing industries. So you
yes,
tend to have a patient if they are working in those background for a long time in their
yes,
50s and 60s, they might convert into malignancies.
yes.
Okay. Any bearing on address? Acha, why do you ask
Uh,
address?
Sir, because first of all, about we would know about diseases which are more common in the rural areas like rhinoscleroma, rhinosporidosis. And then, sir, moreover, we can also know about the socioeconomic status of the patient.
So how do you know socioeconomic status by writing Pune?
Sir, here I have not mentioned a detailed address.
Actually, the address is for any communication in a future. If you want to follow up some with the patient and so that way you should have a complete address for that patient. So always make it a habit to
Yes.
have a complete address. Okay.
Okay,
Now
sir.
coming
Yes.
to the next slide. So it's a unilateral right-sided nasal discharge.
Yes,
Next,
sir.
history of present illness. So you have written it's a mucoid discharge, non-blood stain.
Yes, sir.
Suppose in the
Yes, sir.
what type of discharges do मतलब patient may present with?
Patient can come with a watery discharge, can come with a mucoid discharge, can come with a mucopurulent discharge or a purulent discharge.
Uh, you cannot differentiate completely between mucopurulent and purulent. So you keep it in a same category. And the other kind of
Okay, sir.
discharge is blood stain discharge. So whenever you say
Yes.
blood stain discharge, entirely your thought process goes to some other pathologies, right?
Yes.
So what do you
Yes.
think when patient presents with watery discharge?
Watery discharge are two basic pathologies we have to look at, either an allergic rhinitis or a CSF rhinorrhea.
Okay. And how do you differentiate? What is the typical
Uh,
features of
okay.
CSF rhinorrhea?
So in CSF rhinorrhea, the discharge is more when the patient looks down, and there is no stiffening of the handkerchief or the pillow where the
Why so?
patient
Why
sleeps,
so?
basically.
Why it happens that patient when bent down have discharge?
So it is because of positional, I think. I'm not sure.
Basically, the CSF is collected in the sinuses. So whenever you bend down, that CSF comes down. And
Okay, sir.
what else?
Uh,
Differentiating feature between allergic secretions and CSF rhinorrhea.
so diurnal variation, which will be there in allergic secretions, not in CSF rhinorrhea.
Okay. What else? What happens when the allergic nasal discharge get dried? Heard of handkerchief test?
Yes, sir, I said that. Okay. So there is a halo which is formed in case of CSF rhinorrhea, not allergic rhinitis.
But halo, if the fluid is only clear fluid, then it will be whole. It's a halo test is basically, when do you use halo test?
Sir, to differentiate
When
CSF rhinorrhea with
when
other
you
kind of
want to
bodies.
differentiate whether the secretion has only blood or it's a mix with the blood and CSF,
Yes, sir.
then the blood do not move very much in a capillary action, while CSF being less viscous, it moves away. So it creates
Yes, sir.
a halo all around the blood.
Halo.
So that is a halo test.
Yes, sir.
So, but if the
Yes, sir.
secretions are purely clear, then uh, that will not make a halo. Just hold on.
Sure, sir.
Okay. So in the handkerchief test, it become crisp when dried,
Stiffening, sir.
when the stiff.
Yes,
So cloth gets stiff or
yes,
starchy when it gets dried up. But that's not the case in CSF rhinorrhea.
yes.
Okay. Then uh, when the discharge is mixed with blood, then what will you think of?
So, sir, in children, we can think of fingernail trauma. Then we can think of an impacted foreign body. Then we can
Okay.
think of uh, a, a granuloma, a septal uh, granuloma, sir.
Okay. Uh, it's a when blood is mixed with the other secretion, then you think of either malignancy or some infective pathology. And when it is pure blood, then you think of some vascular pathologies like
Yes.
septal granuloma or angiomatous polyp or JNA.
Hmm.
Okay.
Yes.
Okay. Now foul smelling. What all pathologies present with foul smelling discharge?
Sir, atrophic rhinitis.
Okay.
Then impacted foreign bodies.
It's not impacted foreign body, it's neglected foreign bodies. If you have
Sir,
recently,
long-standing foreign body.
yes, yes. So those are neglected foreign bodies. So what else?
Uh,
A 60-year-old female presented with unilateral nasal obstruction with foul smelling discharge, occasionally mixed with blood.
Sir, allergic fungal sinusitis.
No. Whenever unilateral obstruction or bilateral obstruction with a blood stain discharge, I told you in the beginning, you think of malignancies. You have to rule out malignancies.
Malignancies. Yes.
Okay.
Yes.
So You write, you have written seasonal change. The history is merely of 3 months. Then how can that patient has seen seasonal changes?
So the patient presented to us during this beginning of summer, and they have gone through one seasonal change. So they have described it on basis of that. That it did not
So
aggravate them.
basically, you have to be very careful in choosing your words. You just do not have to fill
Okay.
every each and everything. You should not have written it seasonal change. Okay,
Okay, sir. Yes.
Shelly. Next slide. Nasal obstruction, 3 months, right side, insidious in onset, uh, progressive, complete. Okay, what all do you think when you tell that the obstruction is intermittent or it's permanent?
So whenever the obstruction is permanent, there has to be some mass which is there and
Okay,
which is uh, like we can think of a malignancy, we can think of a papilloma, we can think of a polyp.
and
And
anything
when the
which is occupying
complaint
the
is
space,
yes, sir.
any space
Any
occupying
space
lesion in the nasal
occupying
cavity,
lesion in the
right?
nasal cavity, yes.
And when the
And when we say that it's fluctuant,
it's intermittent,
sir, intermittent can be when the patient has allergic rhinitis.
okay.
It
What else? Anything which is not permanent. Okay, like infections, like
yes,
edema. Okay,
hmm,
you
yes,
have
sir.
written more on expiration.
Yes, sir.
What do you mean by that?
Sir, that the inspirate the during inspiration patient can still feel a little air can go inside the nasal cavity, but while expiration the patient feels no air to go through the right side of the nose basically.
Okay, can you explain this phenomena? Why it happens?
Yes, sir. It is called valve mechanism. So
Okay,
during expiration, during inspiration, there is negative pressure in the nasopharynx and the oropharynx, so the air is able to go in. But during expiration, when there is positive pressure, the this whole mass it blocks the choana,
okay.
so there is no air which can
This can
come out of the nasal cavity.
happen when the mass is present in nasal cavity or nasopharynx.
Sir, basically at the level of the choana, it is
It should go beyond choana. The main bulk of the mass should have crossed the choana. That is, it should be in nasopharynx. Then only you will have a valve mechanism. Okay. If the mass is
okay,
still in nasal cavity, then the obstruction will be complete. At times, you will have a history that it is progressively increasing. Then it becomes complete, and all of a sudden, then a patient have got relief in the obstruction because
hmm,
the mass is increasing, completely filling the nasal cavity, and then it goes into the
hmm,
nasopharynx. The nasopharynx space is more, then it will not block the posterior choana. So patient can breathe through that thing.
okay, sir.
So you may also find this history in at times. Okay,
Yes.
aggravated by episodes of common cold, no relieving factors. ठीक है. Next slide. Okay, tell me what are the 4 5 main history for nasal case. How will patient present to you with the nasal pathologies? What symptoms will you ask for?
uh, so
Two
nasal
you have mentioned.
discharge,
Two
nasal
have,
obstruct, yes, sir.
right?
Nasal discharge, nasal obstruction, sneezing, epistaxis, mouth breathing,
Epistaxis is
snoring.
one. Epistaxis, I give it to you third. Sneezing is not a major symptom. Okay.
Then sir, facial pain or headache.
Facial pain and headache.
Some mouth breathing, snoring.
No, that's associated. What is the function of nose?
Olfaction,
Olfaction.
smell disturbances.
So these are the 5 cardinal histories for any nasal case. And rest all is associated, whether it's a voice change, whether it's a orbital symptoms or mouth breathing or snoring, etc. Okay.
Yes.
ठीक है,
Yes.
चलिए. Patient has complaint of mouth breathing, loss of change of voice in 3 months. Okay. What type of voice change
Right,
will
change of voice.
he has?
So,
What type
sir,
of
the
voice
patient will
change
have
do you
basically
expect?
hyponasality
Hyponasality.
of voice.
So
Yes.
what it is called?
Rhinolalia clausa.
Okay. What do you mean by rhinolalia
Yes.
clausa?
That the patient loses the nasal twang of the voice because of the
Resonance
obstruction
of
of the
nasal
nose. So it can
when
happen
the
in
patient.
cases of.
Why it happens?
It happens in the cases of masses which are obstructing the nasopharynx, like
Right.
adenoid
Whenever there is a
hypertrophy,
see the
then
function of
anticondyl
sinuses.
collapse.
The function of sinuses is to give the resonance to the voice. Okay. Whenever there is a
Yes.
less flow through the nose, then it becomes rhinolalia clausa. It gives hyponasality.
Clausa. Yes.
Then what is the opposite of it?
Yes. It is rhinolalia aperta, sir.
Okay. And what will happen in that case?
Happens in the case. Sir, there'll be more. Like it happens when there is more flow of during talking, when there is more flow of air through the nose and the nasopharynx and the sinuses. When there are cases of like cleft palate or post adenoidectomy patients.
Sorry, I was just looking for the comments which are there. Come again, come again. Rhinolalia
Sir,
aperta.
it's like rhinolalia aperta, like hypernasality basically we call it. So when happens in the cases of cleft palate or immediate post op adenoidectomy patients, or even when we have large nasal masses like an AC polyp, which is in the nasopharynx, after post op, these patients have a hypernasality.
What type of voice will you get in velopharyngeal insufficiency?
Uh,
What is
hyponasality, sir.
velopharyngeal?
Rhinolalia. No, we will get a yeah.
What is
Rhinolalia
velopharyngeal?
aperta, sir.
What
Yes.
is velopharyngeal insufficiency?
Sir, it is when the soft, basically when the soft palate and the
When the soft palate cannot block the nasopharynx,
yes,
है ना? When there is a gap between the passive
yes,
ridge and the soft palate, so the air can leak into
yes,
the nose, or the contents of food may leak into the nose. So there is an increased
yes,
flow in the nose.
yes.
Okay, ठीक है. Okay, next slide. Okay, now just tell me, why have you taken all these history? Acha, what is the function of negative history?
So negative history helps us to exclude whatever are the possible diagnosis we can make on the basis of presenting complaints of the patient. To exclude our certain diagnosis, we take a negative history to reach to a probable diagnosis.
Secondly, when you think of some diagnosis, you have to see how much is the extent of that diagnosis. I mean, where all the disease has spread. So you have to take care, you have to ask for the symptoms if the disease has spread to that region. Okay. Thirdly, you have to rule out or ask about the complications.
Yes.
है ना? Extent, complication, and ruling out certain differentials.
Yes.
Okay. Now, tell me.
So we have taken a negative history for sneezing to rule out allergic rhinitis, a negative history for snoring to rule out adenoid hypertrophy
You have
because
negative
it is a
history of
10-year-old
sneezing
child.
for ruling out allergic symptoms.
Yes, sir.
So, what all allergic symptoms apart from sneezing you will ask for?
So sneezing, rhinorrhea, itching, itching in the eyes or the nose, and nasal block, obstruction.
And any ocular symptom, itching in eyes.
Itching in the eyes, yes, sir. Itching in the eyes
So
as well.
you can also write no history of sneezing. You can club all these symptoms.
Okay, sir.
So
Fine.
that will give a sense to the examiner that you are ruling out allergic symptoms. You are ruling out one diagnosis.
Yes, sir.
Okay. Okay.
Yes, sir.
No history of snoring.
To rule out adenoid hypertrophy, sir, because in this age group, one of the most common causes of mouth breathing and snoring and nasal obstruction comes out
Okay.
to be adenoid hypertrophy.
What are adenoid facies?
Sir, in adenoid faces, we have a high arched palate, we have crowded teeth, we have pinched ala, we have protruding teeth. These are the basic features, sir.
Okay. Okay. Go on. Facial pain, headache.
We have ruled out facial pain and headache to rule out sinusitis.
Acha, what facial pain you ask for?
Sir, we ask
How
whether the
that?
patient is having headache.
Okay. So what does
We
it
would ask
signify?
whether the patient has headache. We would then ask, uh, sir, it will depend on what is the region where the
Site of
patient
pain.
is complaining of headache. So if the patient is complaining more of an occipital headache, we would think of a sphenoid sinusitis. If the
Right.
patient is complaining of more headache on the forehead, then we would think of ethmoid or frontal sinusitis. If the patient is complaining of facial pain lateral to the nose, then we would think of a maxillary sinusitis.
Right. And headache.
Sir, headache occipital or in the forehead area, and then we would
Okay.
ask him the features, him or her, the features of the headache, whether it
Suppose
increases on
suppose
bending down of the head.
suppose in a case of malignancy, patient complains of
Yes, sir.
excruciating headache.
Hmm. We
And
would think of an intracranial extension, sir.
invasion to dura.
We would like to rule out an intracranial extension there.
Okay. Uh, bleeding from nose, fever. Okay, bleeding from nose.
So bleeding
We have
from nose
discussed.
to rule out. Yes, sir.
We have discussed about the causes. So, okay,
Yes, sir.
fever.
We were to rule out acute conditions, sir, like acute sinusitis, acute rhinitis.
Okay. Trauma. Which
Sir,
trauma do you
trauma to rule out with the patient. Which trauma do I?
which trauma do you think will cause unilateral obstruction?
Sir, trauma to the like if there is due to trauma, if there is deviation of the septum to one side, or if
Right, right. Okay. No history of smell disturbances.
Sir, to rule out esthesioneuroblastoma, esthesioneuroblastoma in this case.
Okay.
History of watering of eyes for allergic symptoms, sir.
Okay. What are the causes of anosmia?
Sir, anosmia can be either conductive or it can be a sensory cause. So conductive causes can be when the air cannot reach the olfactory area, can be due to any mass which is obstructing the nasal cavity, can be due to a deviated nasal septum, can be due to excessive crusting in the nose. And then it can be iatrogenic.
Okay.
It can be it can be iatrogenic or any other injury. Then,
So
sir, sensory causes
one
can
is
be like
conductive,
esthesioneuroblastoma.
one is
Huh.
conductive, other is sensory. So in sensory,
Yes, sir.
there might be post-traumatic injury of fibers.
Yes, sir. Then
And
the tumors of the olfactory epithelium.
tumors of olfactory epithelium, or there is a degeneration of neuroepithelium.
Yes,
Can you
which
think
will
of a
happen in
diagnosis
atrophic
in which
rhinitis.
you have
Yes.
both conductive as well as sensory?
Sir.
Atrophic rhinitis.
Yes, sir.
In the atrophic rhinitis, you can have crust so that there will be conductive, air will not reach up to the area of olfaction, and there is a degeneration in the neuroepithelium. Okay.
Yes, sir.
No history of watering of eyes.
To rule out allergic symptoms, sir.
Okay. No visual disturbances.
Sir, to rule out if the tumor is extending somewhere near the orbit or it has involved the optic nerve, to rule out that. Whatever is the pathology, is it involving the optic nerve or is it extending to the orbit?
Okay. Any other orbital sign or symptom?
Proptosis, sir.
Bulging of eye.
Yes, sir.
Okay.
Uh, then, sir, ophthalmoplegia, extraocular movements, they do not happen.
Right. Cheek. Ear pain, ear fullness, decreased hearing.
Sir, to rule out the extension of the pathology to the nasopharynx, whether the pathology has blocked the eustachian tube and has lead to these oral symptoms.
Okay. Okay, go ahead. So this patient does not have any allergic symptoms and is a unilateral obstruction.
No, sir.
Okay.
Yes, sir.
On the basis of your history, can you zero down on some certain diagnosis?
Yes, sir. On the basis of history, looking at the age group, the first differential diagnosis I would think would be an androcoinal polyp.
Okay.
Uh, then I can also think of obstruction and rhinorrhea in case of a foreign body in this age group.
Okay.
Then I can think of an ethmoidal polyp, which is unilateral.
Okay, but there's hardly any allergic symptoms.
Yes, sir. There is hardly any allergic symptoms here. Or, sir, I can think of in children, we can think of a meningocele or a lymphoma.
Okay, what will be the DDs for your unilateral nasal obstruction?
Sir, it can be a hypertrophic turbinate. It can be a deviated nasal septum. It can be an anthropoinal polyp. It can be an inverted papilloma. Then it can be unilateral choanal atresia.
Mhm.
Um,
JNA malignancy.
JNA malignancy, yes, sir.
Okay. So we go ahead with the keeping all these things in mind so that we can differentiate between all these things and come to a proper diagnosis. Okay, go ahead with your
Yes, sir.
examination.
Uh, shall I skip this three parts, sir? Go to the examination directly, or
Yes, yes,
shall I
directly.
start?
No, no, you go to examination part.
Okay, sir. Uh, okay. So on general examination of the child was normal. Uh, Systemic examination was normal.
No, no,
ENT
general physical
examination was.
examination.
You want me to elaborate? The child is conscious, cooperative, obeying, moderately built and nourished. There is no pallor, no icterus, clubbing, cyanosis, lymphadenopathy, or edema. BPI and pulse are within normal limits, and the child is afebrile.
Okay. So you have to write BP
Systemic
in
exam.
which arm, which cuff, which position, and pulse also. So these are basic things which certain examiners want to see or want to hear. Okay.
Okay, sir.
Chalo.
Yes, sir.
Next.
Systemic examination. In the cardiovascular examination, S1 and S2 were heard. There were no murmur. In the respiratory system examination, air entry was bilaterally equal. There were no additional breath sounds. Her abdomen was soft and no organomegaly was seen. And the CNS showed no focal neurological deficit.
Okay. Coming to the ENT
ENT
examination.
exam. Yes, sir. ENT examination was done in proper lighting and after counseling the patient. Examination of the nose. The external framework was normal. There was no nasal bridge deformity. There were no scars seen. The examination of ala and columella was normal.
Okay.
The
What all
palpation of the nose
external?
gave a normal feel.
What all external nasal deformity you know of?
So saddle nose deformity, hump deformity, then taper nose, hebra nose, then crooked
Crooked
nose.
nose. Okay. ठीक है. Uh, what diagnosis will you think if you have a swelling in this region?
So here,
Root of nose. Root of nose.
vestibulitis, sir.
Root of nose. Root of nose.
Root of nose, sir. Um,
Soft fluctuant swelling. Young child. Dermoid. Yes, it could be meningocele also. Somebody has written.
yes.
Okay. Further examination.
Uh, on anterior rhinoscopy, it was done using a thirticum nasal speculum and a headlight.
You have
On the
examined the
right side of
vestibule.
nasal cavity,
Come back to the previous slide. You have not mentioned ala columella. You have not seen the vestibule.
sir, I am supposed to tell about the vestibule and anterior rhinoscopy. Sir. Like that is how I.
No. What is anterior rhinoscopy?
Sir, anterior rhinoscopy is basically examining the nose from the anterior nares,
With
and
the
it can
help
be
of.
done with or without a nasal.
No. Anterior
So it can be
rhinoscopy
done
is
with or
conventional.
without a nasal.
Anterior rhinoscopy is typically defined as examination with thirticum. So before anterior rhinoscopy, you have
Then
to
I would like
examine
to.
vestibule.
Okay, sir. So then I
Why do
would
you
like
want to
to
examine?
mention vestibule.
Why? Yes. Why do you want to examine vestibule first?
Sir, to see if there is any furuncle, there is vestibulitis.
Right.
It is a part of the
Because
dangerous area of the face. So
yes,
we
because it's
want to rule
very
out such
painful. And
pathologies.
if you do not examine the vestibule before and directly put the thudicum, patient will hit you.
Yes, sir.
ठीक चलो तो वेस्टिब्यूल में क्या
Anterior
पैथोलॉजीज हो
rhinoscopy.
सकता है what all thing you can see in vestibule you can see furuncle
So
you can see
furuncle,
swelling you can see
vestibulitis,
vestibulitis
vestibulitis, furuncle.
you can see stenosis
Yes, sir.
you can see swelling because of nasolabial cyst.
Yes, sir.
Okay, so coming to anterior rhinoscopy.
Anterior rhinoscopy was done using a thirticum nasal speculum and headlight.
See, you have
On
written
the
it
right
very clear.
side, mucoid discharge.
You have written it clearly with the help of a thirticum. Okay.
Uh, on the right side, there is mucoid discharge seen on the floor of the nasal cavity, and a pale, glistening polypoidal mass is seen filling the right nasal cavity up to the vestibule.
Okay. Now you have seen certain discharge in nasal cavity. What will you instruct patient to do?
So we would ask the patient to blow the nose and clear off the discharge, so we can see the exact
Right.
pathology
Right.
behind.
So anti-rhinoscopy, you have to see first directly and then after proper decongestion
Yes,
and
sir.
clearing of the nose so that you can get a
Yes.
better view. Okay. ठीक.
Uh, then nose was decongested with decongestant drops.
ठीक. ठीक है.
Probing was done after counseling the patient. The mass had smooth
So
margins. It
no,
could be
wait for. You should tell the pathology once you have written nose was decongested with the decongestant drops and the after clearing of the nose nasal cavity then comes to the pathology. Now tell me about the pathology.
okay. So a pale glistening polypoidal mass was seen filling the right nasal cavity up to the vestibule.
Surface.
The it was probed after counseling the patient. It had smooth margins. It could be probed all around.
The
It was
probing
firm.
test is different. Probing test is different. Before that also by visual inspection you have to see surface margins where all it is touching. What is the color of septum? What is the color of mucosa of septum? Turbinates. You have to comment upon the turbinate. Then comes the probing.
Okay, sir.
Okay.
So, sir, we could see a pale glistening mass which was smooth. It had smooth margins. Then it was filling the nasal cavity up to the vestibule, so the turbinates could not be visualized. Its
Okay.
extent laterally was up to the lateral nasal valve. Lateral nasal wall, it was medially up to the septum. Superiorly, it was touching the roof of the nose, and inferiorly, it was till the floor.
Okay. Right. So what do you find in probing? How do you do probing?
Sir, we take a Jobson probe and we apply a little cotton. We counsel the patient and then we do probing around the mass.
So what
So probing was done. The mass had
uh, what all is there in your mind when you want to do probing? And when will you not do probing?
So we will not do probing when we see the mass. The mass looks vascular to us. We should not do probing then.
Okay.
It might bleed. And while probing, we have to see where all the mass is attached. We have to see whether it's sensitive to touch or not. We have to
Okay.
see the mass consistency and whether it bleeds on touch or not.
Okay. When you say it is insensitive to touch, then what all masses are insensitive to touch?
Sir, anthracoinal polyp,
right?
Foreign body. And if
Right.
I can, no, it will not be a mass.
Inverted papilloma also is insensitive to touch. Polyps and papilloma. Okay.
Yes.
Mm, how do you differentiate it with the turbinate?
Sir, first is decongestion. After putting decongestant drops, the turbinate is likely to shrink if it is a turbinate.
Right.
Second thing,
So
while
it can
probing,
be,
it will be attached laterally.
it
And
should be bony hard,
and
attached to
if
the
it is a
lateral wall.
polypoid mass,
ठीक
yes.
है. Suppose you are not able to go above the swelling, then what do you think? Superior to swelling.
Sir, it is arising from the roof. Then we can think of a meningocele.
And और ऊपर से क्या आ रहा है? अभी तो इतना बड़ा सा नाम बोला था.
Esthesioneuroblastoma.
ठीक. And when it is you cannot go underneath the swelling.
Swellings from the floor, sir. Then
It might be some osteoma, it might be rhinolith.
yes, sir.
These swelling are attached to the floor. Okay. Or lateral wall swelling, most of the swelling are coming from the lateral wall.
Sir, it can be from the lateral wall. It can be inverted papilloma. Then it can be a turbinate. Then it can be polyps. No, polyps will be able to grow. Ethmoidal polyps will not be.
ठीक है. Non-sensitive to touch, then bleed to touch. What all the swelling bleeds to touch?
So hemangiomas, then granuloma, then JNA.
And
So turbinate.
bleeding polypus of septum, somebody has written. Okay. What else? What else? Pyogenic granuloma. Okay, what else? Malignancies.
Sir, rhinosporidosis.
Rhinosporidosis.
Malignancies, then rhinosporidosis.
Inverted
Yes.
papillomas. These all have a tendency to bleed. Okay. You have
Yes.
mentioned rhinosporidosis. What is the typical appearance of rhinosporidosis?
Sir, it gives a woody feel to the nose, and there is Hebra nose or taper nose in.
Rhinosporidosis. I am not asking rhinoscleroma.
Sir,
Have you seen any case of rhinosporidosis? Strawberry appearance.
sir,
Teju. Dr. Teju is very much involved. Good, good. It has a typical mulberry or strawberry-like appearance, red, fleshy, with underneath surface is covered with white sporangias. It may be
yes, sir.
pedunculated or it may be sessile. Readily
Yes,
bleed on touch.
yes, sir.
ओके. चलो. अरे समय खत्म होने वाला है. जल्दी जल्दी. नेक्स्ट. Anti-rhinoscopy left side
So
normal.
anterior and on the left side is normal. Functional test, cold spatula test shows decreased fogging on the right side. Portal's test is negative. Olfaction is normal. There is no paranasal sinus tenderness. Ear is bilateral
What are
normal. TM is
इतना इतना
mobile.
जल्दी में नहीं, इतना जल्दी में नहीं. पहले ओल्फैक्शन कैसे टेस्ट किया?
So it was done using coffee powder. We first checked the pathological side by blocking the left side, and then we asked the patient to smell.
Why?
And then we asked the patient to smell it from the other.
Why on pathological
Because if
first?
we first, because if we ask the patient to do it from the non-pathological side first, the patient would already have a sense of smell for that substance we are giving, and we would give a false
Okay.
positive olfaction on the pathological side.
Okay, and what should not be tested for olfaction?
Sir, ammonia.
Why?
It would rather irritate the trigeminal nerve, and we would have a it would not be olfaction basically. It would irritate the nerve, and then it would
Patient
be a
will
false positive kind of a test.
okay, yes, nociceptive fibers get irritated, and it gives a false sensation that something has been smelled and it has created some reaction in the patient.
Yes.
Okay. ठीक है. So टेंडरनेस फंक्शनल टेस्ट में टेंडरनेस नहीं आता, टेंडरनेस अलग से आता है. पैरानेजल एग्जामिनेशन ऑफ पैरानेजल साइनसेस. So where all do you test for frontal?
Sir, the frontal sinus tenderness is just tested above the medial canthus. The ethmoid sinus tenderness is tested
Just above the
medial to
medial
the medial
canthus.
canthus. And
Why?
so, because we have the floor of the frontal sinus there, which
Most
is the
dependent
thinnest
part.
wall of it, and we can elicit most dependent part. Yes.
Okay, ethmoid.
Ethmoid, we would check medial to medial canthus. And then
Okay.
maxillary, we would
Maxillary.
check at the canine fossa.
What are the boundaries of canine fossa? Standard typical questions.
So superiorly, it is the inferior orbital foramen.
Right.
Then inferiorly, it is the canine ridge. Laterally, it is the canine eminence. And
Canine ridge किधर है?
medially, sir,
Laterally it's canine ridge.
inferiorly and
Inferiorly it's alveolar
okay, sir.
process.
Yes, sir.
Laterally is
And
canine ridge.
medially,
Medially is pyriform aperture.
pyriform aperture. Yes.
Okay. So what is the significance of this canine fossa?
Sir, it can be used to elicit maxillary sinus tenderness, and then it can also be used as an approach to maxillary sublabial approach to the maxillary sinus.
Okay, what does that approach called? What is the name of that?
Cartwheel-Lock approach.
Caldwell.
Cartwheel-Lock
Okay.
approach.
Okay. Will it be used in your case?
It will not be used, sir.
Can you?
It will only, yes, we can, but preferably we would go for an endoscopic
Why?
surgery in this case.
Why?
Because it is a 10-year-old child, and they have not yet got the secondary dentition. So we don't want to damage the roots before by the surgery, sir,
Right.
using
Right.
this approach.
Okay. Next slide. Ear bilateral normal TM. Okay. What is the significance of ear examination in case of nose?
Sir, ear is examined to check whether the pathology we are dealing with has uh, reached up to the nasopharynx or not, whether it has blocked the eustachian tube opening or not. And for that,
Sometimes nasopharyngeal
that is why we
carcinoma
have to
only
check it.
presents with. Sometimes nasopharyngeal carcinoma only presents with glue ear, serous otitis media. Hello, Dr. Rashmi, are you there?
I think we have lost connection with Dr. Rashmi.
Okay, now, okay, leave this presentation and now tell me how will you go about managing this case?
Okay, sir. So for the management, sir, we would first like to investigate the case. For the investigation, we would like to go for a diagnostic nasal endoscopy and
Okay,
a computed tomography with contrast.
okay. So tell me the basic relevance for these two. What significance they bear?
With the diagnostic nasal endoscopy, we will know about the extent of the mass. We would know about its origin,
Right. What are the three
and
passes
with
of?
the so for the first pass, sir, we have to pass the endoscope from the floor of the nasal cavity where we see the nasopharynx. For the second pass, we see the sphenoethmoidal recess, and for the third pass, we see the middle meatus, sir.
Okay.
And then
ठीक है.
we would go for an imaging contrast enhanced computed tomography to see the extent of the disease and to
Won't you won't you
see if there
won't
are
you
any
go for
anatomical
any
abnormalities.
X-ray?
Uh, no, sir, because according to the examination, I would rather go for an endoscopic surgery in this case and would uh, I would anyway go for a CT scan. So I would not prefer doing an X-ray prime.
Okay. What X-ray views do you know of for paranasal sinuses?
So we have the Waters view,
Right. What is the other name of Waters view?
occipitomental view, sir.
Very good. And what is the other view for frontal?
Uh,
Caldwell. Again, Dr.
Card
Teju.
view, sir.
Okay. Good. It is also called occipitofrontal. Can you think of any relevance of occipitofrontal view in frontal surgery? Dr. Teju, let's see. Osteoplasm. Very good, very good. Osteoplastic flap. You have to basically make a template, mark the frontal sinus, and then proceed.
Yes, sir.
Okay.
Yes, sir.
What views of CT scan paranasal sinuses?
Sir, we will obtain coronal, sagittal, and axial sections. But
Okay.
if we have to choose any one section, we would like to go for a coronal section, sir.
Why?
Because coronal section will help us because coronal section is the approach, like how the surgeon goes in for the surgery. So we get the similar view. It is from the tip, so we get to know about at every step we can know the anatomical abnormalities like the surgeon goes ahead.
Okay. So, won't you go for contrast enhanced CT scan in this case? Or
Yes,
in
sir.
other words, in what all cases would you
For
ask for contrast?
for sir any unilateral nasal mass, we would go for a contrast enhanced CT scan only because we have to rule out if there is any malignancy. We have to
So
see
in
what is the vascularity of the mass, like in case of a JNA.
so in this case, you want to go for contrast enhanced?
Yes, sir.
No. You have diagnosed the polyp. The contrast is not given for the diagnosis. It's given for the vascularity. So there is
Hmm.
no need for going for contrast enhanced CT scan in this case.
Okay, sir.
Polyp has a typical appearance. You have already diagnosed it. You just want to have a anatomical evaluation of that patient, and for that, plain CT is good enough,
Okay, sir.
right?
Yes.
Okay. अब कैसे इसको क्या क्या कैसे ट्रीटमेंट करोगे? एंडोस्कोपिकली क्या बोलते हैं उसको?
Sir, we will go for an endoscopic removal of this enterocoinal polyp.
And what is FES?
Sir, we will not call it FES here because we are not doing anything with the sinuses, and we are not basically dealing with anterior or posterior ethmoids or the sphenoid sinus here. So we would rather
It
call it
need
an
not to be.
endoscopic removal of the enterocoinal polyp.
No, it need not to be. FES does not always comprise of going all the steps. What is FES?
Okay. It is functional endoscopic sinus surgery, sir.
Okay.
Wherein
What does it mean?
it means that we only remove whatever is necessary, whatever is diseased or pathological, and we try to retain as much as normal mucosa we can.
So this surgery is endoscopic sinus surgery to improve the functionality of nose and sinuses, right?
Yes, yes, sir.
So won't you be doing the same thing in this case?
Yes, sir.
So it can be called FES.
Okay, sir.
चलिए ठीक है. Hmm, कौन से एंडोस्कोप की जरूरत पड़ेगी आपको इसमें?
So we will need a pediatric 0 degree and a 30-degree endoscope or a 70-degree.
30 डिग्री और 70 डिग्री.
Sir, 30-degree.
ठीक है. If preferred, 70 degree is better because you have to look for wide angulation. You have to see all the walls of antrum. Antrum is also called as, what is the other name of antrum? Maxillary antrum? Dr. Teju. Hi, more. Very good. Very good. Very good. And okay. You heard of Weigand technique and Mesa-Klinger technique? Anterior to posterior, posterior to anterior? Dr. Rashmi?
Yes, sir. I can hear you.
Weigand. Have you heard about this thing, Weigand? So, which among them is more functional or more conservative? The Weigand or the Mesa-Klinger?
So Mesa-Klinger is
Mesa-Klinger.
more functional.
Why? Mesa-Klinger is tailor-made surgery. You do whatever is necessary and come out. No,
Okay,
it's
sir.
not because of landmarks. Mesa-Klinger is tailor-made surgery. It's a conservative surgery. If you have disease only in anti-ethmoids, then you only do anti-ethmoidectomy. If you just want to do infundibulotomy, you just do an uncinectomy and come out. Whereas in Weigand technique, you have to go all through all the 5 steps. Right?
Yes, sir.
चलिए ठीक है. Complications. Quickly tell about the complications of FES.
Sir, complications can be first from the uncinectomy. We can reach the lamina and we can one is that, and then sir
Orbital and cranial complication and bleeding. ठीक है. When examiner asks you more, tell him more. Your answer should be very crisp and very limited. Okay. Okay, I think we can conclude this session. And I must congratulate Dr. Rashmi for giving a very good presentation, and you prepared well. And I must acknowledge the contribution from Dr. Teju. Very quick in answering. Keep it up.
Thank you, sir.
Chaliye. Okay. Any questions? I've tried to answer all those whatever you have written in the discussion only. So other time whenever we came across, then we can take further questions and further interaction.
Sure, sir.
Right?
Thank you so much.
Yeah, thank you very much, Dr. Rashmi Aggarwal, for the presentation, and thank you very much, Dr. Salab Rastogi, for joining us. And thank you, trainees, for joining us.
Okay. Bye bye, and all
Thank you,
the
sir.
best wishes.
Thank you.